physician with fellowship in critical care from Hospital Serdang, and Dr. Muhammad Mukhtar, an experienced anesthesiologist from our Department of Anesthesiology. They will help us understand the critical thinking behind managing dengue emergencies, the kind of insights that you probably won't get from a textbooks. So without further ado, let's dive into our first case with Dr. Nur Farhana.
Assalamualaikum and good morning. Thank you, Prof. Surya, for the kind introduction. My name is Nur Farhana binti Muhammad Izham, medical officer from the Department of Emergency Medicine. Today, I will start off our clinical pathological conference titled Decoding Dengue Key Insights for Emergency Management with a case presentation. All right, we start off with the history. We have Mr. K, a 40-year-old obese Malay gentleman whose chief complaint was fever for 4 days. He was actually referred from a private hospital on the same day of arrival to ED HCTM. He also had vomiting for 1 day, 6 episodes, diarrhea for the past 4 days, more than 3 episodes per day, cough and sore throat, poor oral intake and lethargy, pre-syncope twice at home, no bleeding tendencies, but he had a visit to GP 1 day prior to arrival to our ED. He also had a significant past history of dengue fever 5 years ago, which did not require admission. So on physical examination, patient was alert, conscious. He was tachypnic. He was pink with poor pulse volume, cold peripheries, and a CRT more than 2 seconds. His weight was around 100 kilos. His BP was 101/65, slightly tachycardic with a heart rate of 102. Respiratory rate of 28 breaths per minute, SpO2 96% under room air with a temperature of 37.3. Heart examination was unremarkable. Lungs, we noted reduced air entry at the bases with abdomen tender over the epigastric and right hypochondrium, and the liver was 1 finger breath palpable. On our bedside scan, we found the patient was still under volume as evidenced by the IVC, which was more than 50% collapsible, but there was pleural effusion at the right and left lower zones, and there was also free fluid at the hepatorenal and also the pelvis. So on investigation, as you can see, according to the day of fever, so he went to the GP on day 3, he went to a private hospital day 4, and came to our ED on the same day of day 4 of fever. So as you can appreciate, there was an increase in hematocrit with a concurrent reduction in the platelet. There was also acute kidney injury with an increase in urea and creatinine. And also the all the liver enzymes were all raised, almost 4 times fold increase in the liver enzymes. NS1 was also positive, taken at the GP 1 day prior, which was on day 3 of fever. The chest x-ray as shown here, you can see there's actually bilateral lower zone patchy infiltrates with blunted bilateral costophrenic angle, suggestive of pleural effusion or plasma leakage. Our impression then was severe dengue, day 4 of illness, with severe plasma leakage and multi-organ impairment, which is acute kidney injury and transaminitis in compensated shock. Our differential at the time was leptospirosis, malaria, or community-acquired pneumonia with sepsis. Our plan was to give IV drip 10 cc per kilo per hour crystalloid with strict IO charting, supplemental nasal prong 3 liter per minute oxygen, and to refer to medical and anesthesiology team immediately. Assessment at 1 hour, patient was still in compensated shock. He was alert, conscious, tachypnic, but there was still poor pulse volume, cold peripheries, and a CRT of more than 2 seconds. His blood pressure was 117/91, still slightly tachycardic at 103, and tachypnic at RR of 32 breaths per minute. Clinically examination, lungs still had reduced air entry at the bilateral bases, and he was still having tenderness over epigastric and the right hypochondrium. At this point, 1 hour later, we got a VBG, which showed lactic acidosis with a lactate of 6.8. Impression at this point was still compensated shock, and the patient was given 10 cc per kilo per hour colloid in view of the plasma leakage and admitted to ICU. Patient was then admitted to ICU. He was admitted for 3 days in ICU. He became decompensated, he was more tachypnic, and he was hypotensive. He was started on inotropic support and non-invasive ventilation. He was given IV human albumin in view of the plasma leakage, but as you can see, there was worsening renal function and oliguria, as you can see in the blue table there. And he was started on hemodialysis. With the worsening liver function, with the transaminitis up to 30,000, he was started on N-acetylcysteine. By day 2, due to respiratory distress, he was intubated with increasing triple inotropic support. On day 2 also, he was referred to the hematology team because there was suggestive of hemophagocytic syndrome and started on IV dexamethasone. By day 3, patient became increased, his inotropic support was increasing, his peripheries were cold, he was mottled, CRT was 4 to 5 seconds, pupils were 3 sluggish. Patient passed away on day 3 of admission. Cause of death was severe dengue with multi-organ failure. So other than that, the investigation sent on day 5, NS1, IgM, IgG was all positive. Our leptospirosis and our malaria all came back as negative. So in summary, I hope this case presentation provided an insight into a case of severe dengue. Next, we will learn more about dengue, its management, and the pitfalls of dengue. And with that, I thank you.
Okay, thank you very much to Dr. Nur Farhana. Short, sweet, but very interesting case. Without further ado, I would like now to invite Dr. Nurul Shaliza to dwell with us and unravel regarding dengue clinical manifestation and pathophysiology. Dr. Shaliza?
Assalamualaikum and a very good morning to everyone. Good to be back here today to HUKM. Before I start my presentation, so I would like to say thank you for a kind invitation for me to be standing here to talk about dengue. I'm not an expert, but I am going to share about dengue clinical manifestation and pathophysiology. And part of the discussion in my presentation is come from ETD HKL Dengue Champion Team. They are quite active in training the clinician about dengue infection, and they have extensive trainings along the year nationwide. Okay, so I think when we talk about dengue infection, we also know that this is a common presentation in emergency department, and even a common viral illnesses related to mosquito-borne viral infection that come to the front lines in GP, KK, private hospital. And I hope after this you can get gist of the how you are going to diagnose a dengue and how to categorize a dengue according to the classification. All right, we know that we have dengue 1, 2, 3, and 4. You can get all 4 dengue, and you have a lifelong immunity to dengue. And a transmission of dengue infection can come from person A to person B via a mosquito bite. And you know that caused by Aedes aegypti commonly, and Aedes albopictus. And after incubation period up to 3 to 12 days, and they start to have viremia episode within the bloodstream because of the viral replication in the bloodstream. And 2 days after that, or 48 hours after viremic episode, then you start to have some symptoms. And we know that majorly, even they have a viral infection, but they don't have symptoms, about 75% of patients. And you can also see partly of the patient have symptoms. And not every patient that have symptoms will have a severe form of disease. You can see only 5% of patients will develop severe dengue, in which they have a markedly plasma leakage. Plasma leakage can cause hypovolemic shock, target organ dysfunction, and you have a lot of a complication related to dengue. And if you unable to diagnose and unable to manage the dengue infection, in particular severe dengue, the patient will actually goes to a fatal, and it will actually die subsequently. So a basic about the pathogenesis of dengue. You can see that there are three important mechanisms that may basically related to dengue infection. And primary disorder, when we talk about a primary mechanism in a severe dengue infection, is plasma leakage. So how they're going to get a plasma leakage in dengue is that you have a capillary which is porous. And why the capillary is porous is that because of the integrity of the skin or the integrity of the skin barrier has destroyed because of the virus infection. Right? What we call is the specific layer, what we call is glycocalyx. All right? And also the immune-mediated mechanism in which whenever you have a cytokines, lymphocyte, monocyte, TNF, all sort of inflammatory mediators will also enhance the porous capillary by damaging the endothelial cells. And also, because of immune-mediated related mechanism, the patient will start to have a flu-like syndrome, URTI symptom, viral infection. And if you have persistent hyperstimulation of immune-mediated, what will be happen to the patient? They will have a persistent immune system within the body, and patients start to have a persistent fever. They have persistent target organ dysfunction. They have persistent shock. What we call is cytokine storm, which is occur in this patient. All right. So, and also the last one, abnormal hemostasis caused by thrombocytopenia and also coagulopathy as the end products of the shock state. All right. So if you see at this diagram, I tak tahu nampak ke tak. All right. This is the capillary. You have the endothelial cells as your skin barrier, ataupun kita panggil is the barrier to the capillary, and the junction or tight junction or gap in between the endothelial cells become tight. So you actually don't allow the intravascular compartment goes out. So in dengue, what happened is that it become porous. The tight junction become open because of this endothelial glycocalyx layer has been damaged because of the viruses, the lymphocyte, the NS1 antigen damaging the glycocalyx. Yeah, if you look under microscopy, yeah, you can see that this is a normal status of patient. You have very thick glycocalyx and endothelial cells. It become very tight junction. Yeah, it's a close junction compared to dengue. Whenever you have a very thin glycocalyx, the blue color coding one, all right, and it will start to open your capillary. Yeah, and become porous, and whatever intravascular compartment, especially a larger compartment ataupun component, will goes to the third space, and you have a leaking. The more porous, the more bigger hole at the capillary, the more leak is the patient. Alright. So for a leaking, or kita panggil dalam terminologi leaker, easy to understand. For a leaker, you can see this is normal, very tight junction. This is open, very porous capillary. Your plasma leakage will go out and become concentrated of the RBC and the plasma, and you expect the patient have high hematocrit. So it's easy. A leaking patient will have high hematocrit. They remains in shock and they have organ dysfunction. Boleh? And if they basically remains in a shock state, you don't treat the patient by giving fluids accordingly, correctly. So what happened? They actually can develop bleeding. So you loss of the RBC, all right, then you can see that they start to have a low hematocrit. Yeah, and also they remains in shock. They have a massive bleeding. So most of dengue infection, you don't have overt bleeding. You don't see they develop upper GI bleed at the presentation. Normally, they will have acute bleeding. You don't see the bleeding, but they are bleeding. 4 to 6 hours later in ICU, if you don't transfuse the patient, they develop overt bleeding, which is upper GI bleeding, which is commonly happen in ICU. All right. Some of the patients, they have a mixed bleak and they have a leak and bleed, what we call is bleaker. So easy, they remains in shock. All right. They have sign of fluid accumulation like pleural effusion, pericardial effusion, ascites, all right? And also they actually can have a normal hematocrit because the loss of the leak, they have also loss of the bleed, the RBCs. So easy, shock plus high hematocrit is a leaker, shock plus normal hematocrit is a bleeder or lower hematocrit. Or if normal hematocrit with a shock state, they can be a bleaker, leak can bleed. Alright, boleh Nanti case ni kita go back to the case and we'll see how we actually can incorporate to the pathogenesis just now. Alright, so this patient is 40 years old. It's very straightforward case. They referred to ED with a diagnosis. Diagnosis given is compensated dengue fever at day 4, critical illness. Okay, alright. So as the first thing that as previous speaker highlighted, patient is obese and the patient have a previous dengue infection. We know that in some patient, they have a risk to get severe dengue infection. Okay, in this patient, the patient is obese and the patient is had previous history of dengue infection. And if you have those factors, they actually can progress very fast and rapidly in emergency department and despite in ICU, and they actually require more closer monitoring. They deteriorate very, very fast if they are high risk to get severe dengue. All right. If you see at the presentation, patient have fever, persistent vomiting, diarrhea, URTI, poor oral intake, and pre-syncopal attack. It's something like a normal viral illnesses clinical manifestation. And what normally we means is that we tend to put the diagnosis as AGE or viral infection, right? This fever, URTI, AGE symptomatology, all right? So that is not true. So any patient with fever, think about dengue until obvious otherwise. What I mean by obvious or otherwise is that if you see a patient have lower limb, redness, swelling, suggest of cellulitis coming with fever, then the diagnosis is cellulitis, is not dengue. Yeah, but other than that, if you don't see any source of infection, think about dengue as your first diagnosis. Hence, you will actually take the FBC to help you to diagnose the patient for dengue. All right. So it's very easy if patient have fever plus 2 of the criterias. All right. And also you take the FBC and you can see some abnormalities in the FBC. Right. That's why the WHO come out with a guidelines and checklist, dengue checklist. If a patient have fever in this patient have vomiting and warning sign, lethargic, poor oral intake, and FBC leukopenic, and platelet count which is low. All right, this is probable dengue. What you need to do is just take a kit and send for the dengue serology, and it confirmed to have a positive NS1, and this is a confirmed dengue infection. You just remember, don't actually label patient as URTI or AGE. Just follow the checklist and you know what is the blood that you need to take. All right. So simple. First 5 days NS1 will be positive. After 5 days for primary infection, IgM will start to see in the blood. All right. After day 7, IgG in primary infection will start to see in the blood. So first 5 days NS1, more than 5 days actually you get IgM. After day 7, you get IgG positive. But this is not really true for secondary infection. So you cannot apply this for secondary infection because secondary infection IgG will start to raise at day 4, day 5. IgM most of the time will be negative and NS1 can be negative if they come at day 5. So just go by clinical, see at the lab test, leukopenic, thrombocytopenia, hemoconcentration is dengue until proven otherwise. Managing dengue is not simple. It's a lot of difficulty with regards of dengue. They come with many non-specific symptom, URTI symptom, they mimic URTI, they mimic AGE symptom, diarrhea, vomiting. They come maybe just lethargic at day 4. All right, if you don't have fever, even if they come actually in a critical phase, you just remember not only fever is dengue, but AGE without fever, especially at the critical phase, without fever also is dengue. You can see that some of the pathologies or disease that can mimic dengue. During febrile illness, it can be viral infection, parasite, autoimmune disease, bacteremia. Alright, even it's much more difficult if they come at day 3 or 4 or 5, whenever they entering a critical phase, They can come with a DKA symptom, just epigastric pain, vomiting, but they have thrombocytopenia, that is dengue. Because whenever it's entering the critical phase, the patient will not have fever. That is the difficulty whenever you want to manage dengue. All right. So after you diagnose a probable and confirm the dengue infection, all right, the second part of the classification is to classify patient according severe or non-severe. This is very important. WHO 2009 dengue classification classify a dengue infection into two. One is non-severe, second is severe. Non-severe divided into two without warning sign. You can discharge, with warning sign, admit, and the severe dengue fever require much more intensive monitoring and resuscitation. They can be coming to you with plasma leakage, severe hemorrhage, and severe organ dysfunction. They already labeled what is severe organ dysfunction. If the severe transaminitis AST more than 1,000 or ALT, they can come with encephalopathy, mental states, or they can come with seizure, encephalitis, or maybe they can come with myocarditis and AKI, like this patient. Right, back to this patient. This patient presented to private hospital with a low BP and also a poor perfusion and tachycardia. So you can see that the diagnosis given by private hospital is compensated dengue infection. You agree with that? So the answer is not. This is the compensated shock. Because of the blood pressure is low, perfusion is bad. All right, and it shouldn't start at 5 cc. Later on, we will cover about the fluid management by the next speaker. It should actually given the patient much more larger amount of fluids, which is 20 mils per kilo, as the diagnosis is decompensated. All right, for 7 hours, patient has received about 5 mils per kilo per hour. I'm sure there are a lot of calculated amount of fluids, which is quite large throughout the period monitoring in the private hospital. And in emergency department, again, patient remains in shock. You can see that even though the numbers is good, 101 is 60. That is not okay for an obese patient. An obese patient should have much more higher BP than this. If you look, the definition of hypotension is less than 90/60. But it cannot be applied for all patients. You need to see at other parameters to see the numbers is really not in shock. But for this patient, BP 101 and 60 is a little rather low for an obese patient. They will normally have higher blood pressure than this. All right, and the patient start to have leaking. How we know patient is leaking? Patient have pleural effusion, all right, tender liver, and then we can use ultrasound. Patient develop ascites as well. That is a sign of leaking. And the lab test is very simple. All right, whenever you have hematocrit high, platelet thrombocytopenia less than 50,000, this is a leaking patient. All right, and BBG acidosis because patient in shock. All right, and patient have transaminitis because of shock, AKI because of shock. So that is a complication of the shock. So it should be given a diagnosis as decompensated shock plus severe plasma leakage, so that the management will be different. So if decompensated 20 mils per kilo, the choice of fluids will be colloid. At this particular time, is much more shorter duration of fluid management, which is 15 to 30 minutes of fluid resuscitation. So how we differentiate a patient to have compensated and decompensated? Because management is different. You need to know normal. You need to assess head to toe. You need to touch the patient so that you know which category of the patient in the shock state or maybe non-shock state. Alertness, that will be number one. Then you need to touch for the CRT, extremities, peripheral volume, and heart rate, and the BP from the vital sign, pulse pressure, which is very important. So this one normally kita tak guna sangat. But you should be able to do this at the bedside. It's a systolic blood pressure minus diastolic blood pressure, respiratory rate, and urine output. And another thing which is important is urine output. So I don't see any urine output monitoring in this particular patient, maybe not documented. So any shock patient should have a CBD in and proper urine output monitoring, because we want to know which category of the patient to hear. So in these particular cases, after patient receive, I think, more than 30 mils per kilo, patient remains in this state. Patient have a persistent metabolic acidosis, narrowing of the pulse pressure, patient hypotension based on the the baseline of the patient, and patient perfusion remains cold, clammy, pulse volume poor. So I will put the discussion for the labeling of this patient as a decompensated dengue shock, and the management will be different. So again, this patient developed severe plasma leakage and AKI and severe hepatitis. So no issues. Patient is severe dengue fever in decompensated shock. And again, I already talked about it. A leak marker for dengue, easy. For the lab test, you see high hematocrit. Okay, female we take more than 40, male we take it more than 45. Anything above it we call is a raised hematocrit. All right, and also severe thrombocytopenia less than 50K. All right, and low albumin. This is a leaker marker. If you have this, you scan, you examine patient properly, look at the chest X-ray for the evidence of leaking, pleural effusion, pericardial effusion, ascites again. All right, and perfusion markers, metabolic acidosis, and high lactate as complication. So for this patient receive 5 mils per kilo per hour over 7 hours, 10 mils of crystalloid, and give another 10 mils of colloid. All right, subsequently, all right, then the hematocrit remains higher. Hematocrit is 53, and HB normal, and platelet 12. You know that patient remains in shock, hematocrit high. The answer is patient remains in leaking. All right. Okay, so that is very easy. So in some patient develop bleed as well. So bleed easy, shock, high hematocrit, leaking, shock, low or normal hematocrit, bleeding. All right. So you can see from the trend, I dapat daripada slide semalam, so I guna you punya slide semalam. But it's very easy to understand. You can see at 8 o'clock on 20th, after this patient received 10 mils per kilo of crystalloid, you can see that hematocrit is 53 from here, platelet is 12. Patient remains in shock, so this patient is a leaker. They have a plasma leakage. All right, and you see at the side, all right, whenever patient admitted to the ICU, you can see that the hematocrit level is reducing trend. Okay, then easy, patient remains in shock, hematocrit reducing in trend despite fluid, you know patient is bleeding. All right, so the first one is leaking, the second one is bleeding. Why it is important? Because the way how we're going to manage the patient is different. Leaking, we give fluids, in particular colloid. If bleeding, we give a blood products. So that is a different. So we know that after patient develop at 4 o'clock, this is bleeding, 6 hours later you can start counting and patient will develop upper GI bleed subsequently after 6 hours. That's how the dengue evolution happen. So I saw a lot of cases in Sedang Hospital. We have a lot of dengue upper GI bleed, and normally in ED they have occult bleeding. You only see the reading is not normal, patient in shock, hematocrit normal. They have occult bleeding, no obvious bleeding. 6 hours later, ICU, they develop all the upper GI bleeding. That is common for dengue. All right. Okay, so the third one is phases. I'm going to just close off my presentation about 2 or 3 slides. Okay. All right, this is also important, the phases. First one, is it dengue or not? Number 2, classify the dengue into the WHO criteria, non-severe and severe dengue. The third one, look at the phases of dengue. All right. So WHO divided the dengue into 3 phases. One is febrile, critical, and recovery. All right. Minimal leakage will actually miss this period of critical, but most of the dengue patient will have these 3 phases. All right. So they start with fever, first 3 days. All right. At the end of the febrile phase, you can see from here, the effervescent, where the temperature start to drop less than 38 and remains below 38. That is the effervescent. So you know that at that point, whenever they develop temperature rapid drop less than 38, it will entering a critical phase over 48 hours. Yeah, so at day 5, all right, and subsequently, if the patient disease improve, patient will recover subsequently. All right. So how we know which category of the patient have? Of course, we look at the temperature. At what particular temperature? Is it more than 38, less than 38? But that is not really. It's just a guide. It can be overlapping. Patient can have a biphasic fever even at this critical phase or at this day 5 and day 6. All right, but most of the time, 38 febrile, less than 38 remains below 38. It will actually coming to the critical. That's number 1. Number 2, you can see that patient develop warning sign at this end of the febrile, which actually telling you that patient entering a critical phase. All right. Number 3, you look at the lab test. Okay, in febrile phase, it can be everything normal at day 1. Ambil FBC normal, total white cell normal, platelet normal, hematocrit pun normal. But at day 2, day 3, they will start to have leukopenia first. Total white cell will drop first, followed by the reducing trend of platelet and normal hematocrit. Low total white cell, normal hematocrit, low platelet. That will be in the febrile phase. So whenever they entering the critical phase over here, you can see that they start to have a leaking. So they leak a lot. So the hematocrit start to increase. Alright, and the platelet rapid drop. And total white cell can be higher, normal or lower. Higher if patient has bleeding, lower if patient have leaking. Alright, so normal also is mostly can be happen as well at this particular area. Don't look at the total white cell. Alright, and when they recover, they actually will recover, hematocrit will be stabilized. Alright, then followed by the increasing of total white cell, and platelet will go and increase the third phase after the total white cell. So improvement of hematocrit, improvement of the total white cell, improvement of the platelet subsequently. Alright, and patient generally okay. So this is very important. Why? Because the complication is different. If patient is dehydrated, you give fluids. If patient here shock, you need to determine either patient is leaking, giving fluid. If patient bleeding, giving blood. If patient have organ dysfunction, maybe you need a supportive treatment. For example, an AC. In this patient have liver injury, you can start an AC or some of the other supportive treatment like dexamethasone in the HLH. That is expanded dengue syndrome. It's quite difficult. Alright, so recovery. Okay, this is common. We tend to give and get the patient into the fluid overload. Kenapa? Because we keep on giving 5cc, 10cc, 5cc, 10cc, patient dah boleh minum. So what happened here, the third space loss, that going to the third space, start to reabsorb back into the intravascular. Whenever patient on top of the reabsorption of fluid into the intravascular, what happened? You have a lot of fluid inside intravascular. Alright, you keep on giving patient fluid and patient develop fluid overload. So it's very important to know about the phases. So I think as conclusion, another 2 slides. Fever 2-7 days can be biphasic. Yeah, critical phase easy whenever the temperature start to drop less than 38 and remains below 8, and patient to start to have a warning sign and decline in the platelet and rise in hematocrit. And recovery very easy. Patient general well-being improve, everything stabilized, lab test hematocrit normal, total white cell increasing, platelet increasing. Boleh ya? Alright, so that is a very simple discussion on the pathophysiology. So I think for my presentation, I'm using this still 2015. We are still in the construction of new guidelines on 4th edition, will be come out in 2026. Yeah, so they already discussed about it. And this book is very important. This is the book that we use in emergency department, has published and authored by Dengue Champion Team HKL. If you want to buy from HKL, you can just contact them. It is very recommended book because it is not covered in the CPG. It's very detailed on how to recognize and how to manage as a frontliners. Yeah. So I think with that, and thank you.
Okay, thank you so much, Dr. Nurul Shaliza, for a very insightful and comprehensive presentation on the pathophysiology and clinical manifestation of dengue. So the explanation from Dr. Shaliza on how dengue impacts the body and its progression from mild to severe dengue and also into shock, hopefully will provide you a better understanding of this complex disease. So now we'll continue our discussion, going deeper into the fluid management of dengue, which is the cornerstone of dengue management. And please join me to give a warm welcome to Dr. Nizam Mukhtar to enlighten us on fluid management in dengue.
Okay, Assalamualaikum and a very good morning. Thank you, Dr. Shamsuriani, for the very kind introduction. And I would like to thank Department of Emergency Medicine for inviting me for giving a talk to all of you today on fluid management in dengue fever. So I come from Department of Anesthesiology and Intensive Care. So I'm not really a fluid expert. I mean, not really a dengue expert, but I'll try to walk you through what we do in our critical care setting or the initial management of dengue in terms of fluid management. So when we talk about management in dengue, okay, there's actually three things: fluid, and also fluid. Okay, that's the main aim in our dengue management. So that's our main things that we need to manage patients who are coming in for dengue fever. So the first 5 questions that you need to ask patients who come in with dengue fever before initiating a fluid regime. First, what day of illnesses are they when they came in? Is it day 3, day 5, or day 8? Okay. At what phase is the patient in? Is it a febrile phase? Is it a critical phase? Or is it a recovery phase? And the third question is there any evidence of reduced tissue perfusions? Meaning by there's a reduced capillary refill time, there's a reduced impulse volume, also there's a cold peripheries. And the fourth question is, was the patient in shock? So meaning that the patient hypotensive, tachycardia, reduced pulse pressure at presentation. And the next question is, does the patient have any fluid restrictions in terms of their comorbidities like end-stage renal failure or heart failure? So what's the relationship between febrile phase and also fluid administration? So hydration is important as it prepares the body in terms of going into the critical phase, so ensuring there's a stable hemodynamics. Okay? During the febrile phase, patients often lose fluids in terms of the fever-induced sweating. If the patient has warning signs, there will be vomiting and also diarrhea. So these are the places that the patient will lose their fluids. So careful fluid balance is actually important to maintain adequate intravascular volume, as this allows transition into the plasma leakage phase later. Okay? With good hydrations, the risks associated with sudden hypovolemia or worsening dehydration during critical phase are minimized. So how much of fluid we need to give to this kind of patient? So the best way is you need to clarify the patient's condition first. Okay? If the patient has dengue fever with warning signs without any evidence of shock, so what you need to do is you need to maintain the fluids between 1 to 1.5 mils per kilo per hour, and you need to encourage the patients to take the fluid via orally. Okay? And you need to review the patients quite frequently, okay? Within 1 to 2 hours period of time. And you assess the patient clinically in terms of the pulse volume, CRT, the vital signs. So when we talk about warning signs, I think Dr. Shaliza already mentioned earlier on. So there are the abdominal tenderness, abdominal pain, persistent vomiting, okay, meaning that there are more than 3 times a day of vomiting, persistent diarrhea more than 3 times a day, clinical fluid accumulation, mucosal bleed, lethargy, confusion and restlessness, tender liver, increase in hematocrit level, and rapid rise in platelet count. Rapid decrease in platelet count. So when I talk about body fluid just now, in terms of fluid management, what are the body weight that we use? So as we mentioned, patient who has normal BMI, so we will use the actual body weight in terms of calculating the fluid regime. So as I mentioned earlier, with the warning signs, without any evidence of shock, we just use 1 to 1.5 mils per kilogram based on body weight. But as mentioned in our case scenario just now, our patient is actually obese. So do we use the body weight for an obese patient, actual body weight for an obese patient? The answer is actually no. So if the BMI is more than 27 kilogram per meter square, we use the adjusted body weight. Okay? So how do we calculate the adjusted body weight? It's basically ideal body weight plus 0.4 actual weight minus the ideal body weight. So the ideal body weight has to be calculated beforehand. It's based on estimation. Female is different and male is different based on the formula given here. Okay. So now we decide already the fluid, how much that we're giving. So what type of fluid that we need to give in terms of maintaining fluid administration for dengue patient? So should I give Hartmann's solution? Should I give normal saline? Should I give geloflucin or gelofundin or albumin or even dextrose-containing solution? So based on current evidence, isotonic crystalloid solutions are recommended as the first line for maintenance fluid regime in dengue fever. Okay? This is either Hartmann's solution or normal salines. So we need to avoid hypotonic fluids such as half salines, dextrose, and also any fluids that contain low sodium concentration, as they can actually worsen the plasma leakage, as mentioned by Dr. Shaliza just now. Okay, so now you noted that the hematocrit persistently high, okay, with persistent warning signs. So what we do next in this kind of patients? So now we know that the patient is already compensated shock, evidenced by the increase in hematocrit. So now we need to give the fluid in a different regime. So this is called the graded fluid regime. Okay. At this point of time, high dependency unit like a high dependency medical ward or ICU needs to be referred for more close monitoring. So what are the compensated shocks? So it falls between here, which is clear. So the consciousness is still, patient is still conscious, and there's a persistent prolonged capillary time, okay, slightly more than 2 seconds, cold peripheries, weak or steady pulse volume, tachycardia, but the pulse pressure is still, the systolic pressure is still normal. Okay, there will be postural hypotension, slightly narrowing pulse pressure, but not below 20 millimeter mercury, slightly tachypneic, and reduced urine output, and also increase in thirst. So what do we need to do is actually, if you noted that the persistent in warning signs, okay, what do we need to do next? You allow fluid boluses in the graded fluid regime by giving 5 mL per kilo over 1 to 2 hours, and then you can reduce the fluid regime after the 2 hours by assessing the patients to 3 milligrams per kilo per hour, and then you can reduce to 2 milligrams per kilo per hour according to clinical response. So basically, it's a graded fluid regime. You assess quite frequently. Okay, if the patients need to cut down the fluid, you need to cut down the fluid regime. As I mentioned, assess frequently and review the infusion rate accordingly. Okay, if the hematocrit remain high and clinical parameters worsening, you may actually prolong the duration of infusion, and you may increase the infusion rate up to 7 mL per kilo per hour. And beware, at this point of time, maybe the patient is going into the decompensated shock. So now that the patient goes into the decompensated shock, so how would you manage the fluid now? Okay, so you need to know the differentiation between compensated and decompensated shock. Okay, like Dr. Shaliza mentioned just now, the patient actually come in already decompensated shock. Okay, so basically the fluid regime that was given, which is 5 mL per kilo, is actually inadequate. So at least you give 5 milligrams per kilo of crystalloid or colloid first, then you assess the patient. Okay, if not improving, then you can give up to 20 milligrams per kilo. So you give another 10 mL per kilo of crystalloid, okay, or colloid. And then if the BP is still low, and then they will see that the hematocrit is dropping, okay, there is a sign of occult bleeding. Okay, you don't know what, occult bleeding means you don't know where's the source of bleeding, but you know the hematocrit is dropped. Okay, it's good that you can see the bleeding if the patient has upper GI bleed. But if there's no bleeding and then the hematocrit is dropped, then the next step is actually you need to transfuse the patient with blood. Okay. At this point of time, lactate trend will be quite interesting. Okay. So lactate is actually the rise of lactate can mean a lot of things, but in this kind of case, it will mean that there's a bleeding somewhere in this kind of dengue patient. Okay. So regularly assess the response and also the clinical state. So as mentioned, the dengue clinical presentation will be here. There will be change in mental status. Okay, there will be also cold and clammy peripheries. There will be febrile pulse pressure. There will be narrowing pulse pressure. There will be hypotension and also tachycardia. There will be slight metabolic acidosis, and the patient might be oliguria or even anuric at this point of time. Okay, so now that you've given some fluid, so how much is actually enough fluid? So what do we need to do? So you need to measure the fluid response in this kind of patients. How do you go about that? Okay, so measuring the fluid response in dengue patients is crucial to actually ensure adequate fluid resuscitation. Okay, avoid under-resuscitation, and also you want to prevent over-resuscitation, meaning that you lead to fluid overload. Fluid responses can be monitored by 3 main components. 1 is actually the clinical response, 2 by hemodynamic response, and 3 by laboratory response. So clinical response by improving the heart rate and blood pressure, pulse pressure widening, capillary refill time is already reduced, urine output is better, mental status is actually improved, and also warm peripheries. Okay, the hemodynamics, you need to mention the central venous pressure. Okay, so you need to look at this CVP. Point of care ultrasound will be quite important if you have the luxury to do that if you are in a tertiary center. Inferior vena cava collapsibility by using an ultrasound. Again, heart rate and blood pressure using the hemodynamics, passive leg raise test, and also sometimes in a critical care setting, we have these special things which is called the minimally invasive cardiac output monitoring, where we can measure the stroke volume variation, you can measure the stroke volume resistance index, cardiac output, and cardiac index. Okay. In terms of laboratory, you can send the bloods to look at the appropriate decrease in hematocrit level, okay, the electrolyte balances, as well as the kidney function, arterial blood gases to look for any improvement in terms of metabolic acidosis, and then you want to see the decrement of the lactate level. Okay, this is just something interesting which we do in our intensive care setting. Okay, this is actually monitoring in one of the extra monitoring that we have in our intensive care, which is called the cardiac output monitoring. Okay, we do this based on the arterial line that we inserted as well as the central venous line. So from here, we can actually assess the patient's fluid responsiveness. Mainly, we look at the SVV, which is the stroke volume variation here. Okay, so volume variation can tell us how much fluid is needed for this patient, whether the patient has adequate fluid resuscitation or not. Okay, and then the other parameters that we can look is actually the SVRI, the systemic vascular resistance, and also cardiac output. So this will actually target the patients whether if the patient has adequate fluid resuscitation based on the SVV. If it's adequate, then you can look at the cardiac output, why the BP is still low. Maybe at this point of time, you might want to start on inotropic support. Okay, that's why in a patient who are compensated shock or decompensated shock, you actually have to refer to the intensive care also or the high dependency unit so that we can have a proper close monitoring this kind of patient. So the 5 common pitfalls in fluid therapy. Okay, 1, unnecessary fluid boluses, okay, based on a sole parameter. So if you see just the lactate increase and you give bolus, it's not right and it's not wrong, but you actually have to look at other parameters as well to judge, is this patient need more fluid to be resuscitated? Okay. Second, excessive and prolonged fixed fluid regime in a stable patient. So meaning that you don't really assess the patients very closely. You continue the infusion 5 ml per kilo per hour until the patient has overloaded. Okay, infrequent monitoring and adjustment of infusion fluid. So basically, in this kind of cases, as I mentioned, close monitoring in dengue fever is very important. Okay, you need to assess every 2 to 4 hours in a warning signs patient, and even more closer in compensated or decompensated shock. Okay, again, continuation in intravenous fluid, even in a recovery phase. Normally, patient can already take orally in this point of time. Okay, already resorptive symptoms. So if you give more fluid in this point of time, okay, patient will get overloaded. And the last one is actually excessive fluid therapy in patient with comorbidities. So this kind of patient who has heart failure, who has reduced or limited fluid intake, okay, like heart disease and renal disease, end-stage renal failure, you need more extensive monitoring and more subspecialty management in terms of fluid administration. Okay. So the take-home message from fluid management, okay, if you can't remember anything, just remember, start fluid treatment as early as possible. Always encourage orally if the patient can take orally. Thirsty is a good sign, okay, meaning that the patient can take orally. Inappropriate intravenous therapy has been shown to prolong hospitalization. Remember, rising hematocrit may show ongoing plasma leakage. Okay. And careful on fluid management when patient entering critical phase. And also consider discontinuation of IV fluids when patients enter the recovery phase. With that, I thank you. These are my references.
Okay, thank you so much, Dr. Nizam, for that excellent and detailed presentation on fluid management in dengue. I hope now that you have insights into the careful balance of fluid therapy and have essential tools in managing dengue patient. We have one last slide, which is only focusing on the common pitfalls in the managing dengue. So, without further ado, I will continue to cover, just summarize a bit on what are the pitfalls in managing dengue. So, your first pitfall is actually misdiagnosis. So, dengue, as explained by Dr. Shaliza earlier, can be easily misdiagnosed for other viral illnesses. Yeah. So, for example, lepto, chikungunya, yeah, and also influenza viruses. The presentation of abdominal pain, vomiting, diarrhea, myalgia, arthralgia can easily be misdiagnosed. Yeah, usually in emergency department, patient comes in with abdominal pain and vomiting. You can easily say it's acute gastroenteritis or it's actually gastritis. So what's crucial to remember is that in dengue patients are typically more ill than your common upper respiratory tract infection. So what is very important in dengue is actually very paramount to have an adequate history. Yeah. So don't just focus on the current symptoms, like this patient has a previous history of dengue 5 years ago, so that predisposed this patient to severe dengue. The second thing is that, as you see, this patient presented in the critical phase. So the patient was afebrile. So in some patient, we were lucky because this patient was referred to us from a private hospital. So the diagnosis when referred was already dengue. But let's say this patient comes into triage, afebrile, and presented with non-specific symptoms, it can be easily missed to say that it is dengue fever. Just because, at the end of the word dengue, there's fever. So everybody assumed that patients with dengue fever should have dengue, should have fever. So last but not least, to be careful on the misdiagnosing dengue in a vulnerable population, for example, in elderly and as well as children. So resist the temptation to quickly label symptoms as just another viral infection. Take the time. Those extra few minutes could be very crucial. Conduct a thorough assessment and always maintain a high index of suspicion. So the second pitfall is delayed recognition of severe dengue or even shock. Yeah. So your patient may look stable. Vital seems okay at the first glance, but dengue is very, very sneaky. So it can turn from stable to shock faster than you can actually finish your coffee. So in our busy ED, this can be easily missed. Yeah. So why does this happen? Let's say you've got a patient who you saw who has slightly tachycardic. Your heart rate is about 110, but the patient has a temperature of 38.5. So you assume that the tachycardia is secondary to that rather than due to shock. A blood pressure that looks normal, yeah, at a first glance, okay? But maybe the patient also have some cool fingers, cool peripheries, but ED is always cold anyway. So you tend to disregard that. So when in doubt, calculate the shock index, heart rate divided by your systolic blood pressure. If your shock index is more than 1, then you know that your patient might be heading into trouble and they are already in shock. So in dengue, it's actually not about waiting for the obvious signs of shock, but by then it's probably too late. It's about catching those subtle signs early. So how do we avoid? So what's the winning strategy in our primary care ataupun as the frontliner? It's all about CCTVR. It's not your CCTV, CCTVR. So explained earlier, C is for color of the skin. Another C is for capillary refill time. T is for temperature. V is for volume for the pulse. And R is for the rate of the pulse. So along with your blood pressure, pulse pressure and urine output, if you monitor it hourly, that should help you or assist you in managing severe dengue and prevent your patient going into shock. So the thing about dengue, it's like a chameleon. So it keeps changing colors. Yeah. So your patient might look fine now, but they can talk to you, drink water, chat with the family, but within just few hours, they could be fighting for their life. So look at this dengue chart. Can you see the circle that I round? So if you see, the patient initially presented with normal blood pressure. This is not our patient. This is just an example. And within the next 1 or 2 hours, you can see that there's narrow pulse pressure, of the patient, and the patient already going into critical phase and severe dengue. Okay. The third pitfall is analyzing isolated FBC. This is something that we may have, a syndrome or a trap. We call a single snapshot trap. So you have to think dengue like watching your Netflix series. You watch one series, you don't get the whole story or the story plots. So you have to watch all the series. Then only you will understand the whole story plot. So the same with dengue. If you only interpret only one snapshot of FBC, you will not be able to see the trend of dengue itself. So what is the main character? As I explained earlier, it's always your hematocrit. A high hematocrit suggests leaking. A low hematocrit suggests bleeding. Okay? Platelets always play a supporting role. It's not the main actor. Surely it will drop because that's the normal pathophysiology of dengue. It does not tell how critically ill your patient is, okay? And there's another wild card, which is your white cell count. In early part, your white cell count may become low, as explained as Dr. Nurul Shaliza just now, leukopenia. But suddenly, if you look at the trend, it spikes up. So your patient may have complications such as sepsis or even bleeding. Okay. Last but not least is NSAIDs. So it's common for patients to have severe headaches, muscle pain, high fever, myalgia, arthralgia, and requesting for analgesia. So we tend to, as being a good doctor, we wanted to prescribe them some analgesia, but be very careful, avoid NSAIDs. Mainly because NSAIDs affects platelet dysfunction. And with a patient who's already have thrombocytopenia, this is disaster. So the patient can go into bleeding, with NSAIDs. So what can you use? Paracetamol or acetaminophen is something that's quite safe. However, you still have to be very cautious. Like in our patient, he has liver derangement. So very, very cautious in patient with liver derangement and try to avoid them. So as a wrap up, some key points, Managing dengue, you have to be a detective, along being a doctor lah. Okay, you have to be a detective as well. You have to watch your patient like a hawk. It's very sneaky. 1 minute they are chatting to you, and the next time they will be crushing in front of your eyes. Secondly, you have to master the fluid dance, like explained by Dr. Nizam earlier. Too much, too little, It's like being a barista. Who likes coffee? I like coffee. So the perfect brand brew is the one that you need to have a perfect amount, a good coffee. So if you master your fluid management, you are halfway to victory. So the third one is blood tests, not to look at a snapshot, but actually to look it in a trend, like Netflix series. Siapa suka Netflix? Saya suka Netflix. Okay. So finally, keep the NSAIDs away. NSAIDs in dengue is like throwing matches and at a gas leak, and boom, it will fire and will cause problems. Okay, I think with that we thank you. Do we have time for the 3 questions quickly? We have 3 questions. Ada ke masa?